My name is Terry Mamounas. I'm the medical director of the Comprehensive Breast Program of Orlando Health UF Health Cancer Center in Orlando, Florida. So when it comes to axillary dissection, actually, there can be any surgical complications that we usually see, such as bleeding, infection, of course, are fairly uncommon. But most of what happens after an axillary dissection is what we call adverse sequela. In other words, things that we sort of deliberately induce because we have to, for example, remove some of the sensory nerves and cause dysesthesia, or removing lymphatics and lymph nodes and cause lymphedema. So some of these are not necessarily complications. In other words, not unexpected complications, but it's because of what we do. So the main adverse sequela are dysesthesia, as we call it, or pain under the arm, and hyperesthesia, which is like sensory loss of the sensation in the inner arm. This is because we remove the intercostal brachial or some of the intercostal brachial nerves during axillary dissection. Now, the loss of sensation can be variable and sometimes actually can improve over time, but sometimes it takes 2 to 3 years before the patient knows exactly how that's going to feel. Most of the dysesthesia, the pain under the armpit, is temporary and usually within 6 months is reduced substantially. But the hyperesthesia or the loss of sensation can persist and sometimes for a lifetime. Obviously, the more important adverse event after an axillary dissection is the development of lymphedema or arm swelling. And rates of lymphedema with an axillary dissection can range to about 20 to 25%, and clearly are higher if you follow the axillary dissection with a radiotherapy, either to the breast or to the chest wall or to the regional lymph nodes. Of course, all the adverse events of an axillary dissection can be minimized with performing sentinel lymph node biopsy, so minimizing the extent of the removal of the nodes from the axilla. And as I mentioned before, several randomized clinical trials have shown that by doing sentinel lymph node biopsy, you can minimize the development of lymphedema. Now, lymphedema can also be managed conservatively with compressions and lymphatic massage and arms, sleeves. But also more recently, there have been surgical approaches to managing lymphedema or preventing lymphedema. One is the lymph node transfer to the area of the axilla. You can take pedicles of lymph nodes from, let's say, the groin and transfer them to the axilla surgically. And this is a vascularized flap that induces some sort of lymphoangiogenesis. But more recently, we started looking at a lympha procedure, as it's called, a lymphovenous bypass, in which case you bypass the lymphatics that are severed during the axillary dissection to a venous branch from the axillary vein, and that reestablishes the drainage of the axilla to the vein. So this is a very promising procedure, has been shown to produce good results in small phase 2 studies, single institution experiences. And now most people are using it more and more, both from the treatment of lymphedema and lymphedema occurs, but also for potential prevention of lymphedema at the time of a completion axillary dissection if you have to do it. So again, reducing the need for axillary dissection is the best prevention of the complications. But then if you have to do it, we now have some surgical approaches and, of course, some conservative approaches in the management of lymphedema. We obviously have all the patients to see lymphedema specialists after surgery in the axilla to tell them what to do to prevent the development of infections, or, for example, avoid, cuts in the arm or the hand, things that potentially can introduce bacteria that normally will be cleared quickly through the lymphatics, but if there is blockage because the nodes have been removed, you can get cellulitis that also you need to intervene quickly with antibiotics when that happens to minimize the risk of scarring the potential development for lymphedema.